In this lecture, we will be continuing discussion of Chapter 7, but we will be discussing Ambulatory Surgical Center Prospective Payment System. Designated surgical services may be provided to Medicare beneficiaries in the outpatient setting at ambulatory surgery centers under Medicare Supplementary Medical Insurance, or Part B. In an effort to control healthcare costs, CMS introduced a prospective payment system for ambulatory surgery centers in 1982. In order to qualify for payment, the facility must be Medicare certified. These are the criteria that must be met to be Medicare certified. The surgical center must be a separate entity and have their own national identifier or supplier number. They must maintain licensure, accreditation, and they must have professional supervision, administrative functions, clinical services, record keeping, and their own financial accounting system. The sole purpose of delivering services in connection with surgical procedures does not require an inpatient admission. As a Medicare certified ambulatory surgery center, the facility must accept Medicare reimbursement as payment in full for services supplied to Medicare beneficiaries. So basically, Medicare will pay 80%, the beneficiary will pay 20%. If there is a remaining dollar amount, that has to be written off by the facility and cannot be billed to the patient or the beneficiary. Payments for procedures allowed in an ambulatory surgery center setting is really intended to reimburse those facilities for their resources extended to provide surgical services in that locality. The costs of the physician's professional services are excluded from the ambulatory surgery center payment. Professional services must be reported separately. The Omnibus Budget Reconciliation Act of 1980 amended the Social Security Act in order to create a prospective payment system for ambulatory surgery centers. With the adoption of ambulatory payment classifications, or APCs, for the ambulatory surgery care or surgery center setting, Medicare moved from an inclusion methodology for approved services to an exclusion methodology. Using a payment indicator system similar to the one used in the outpatient prospective payment system, Medicare identifies each year in the Federal Register which services can and cannot be performed for Medicare beneficiaries in an ambulatory surgical center. By creating a list of appropriate outpatient surgery procedures, CMS influences the site of service for certain procedures. The list of approved procedures really creates a motivation for procedures to migrate from more expensive inpatient settings to a less expensive outpatient surgery setting. In 1987, CMS implemented selection criteria in order to assist with the ambulatory surgical center list maintenance. CMS used quantitative criteria in order to identify procedures to be added and deleted from the ambulatory surgical center list. If a procedure was performed on an inpatient basis 20% or of the time or less, it would be excluded from the list. Likewise, if a procedure was performed in a physician office 50% of the time or more, it would be excluded from the ambulatory surgical center list as well. Applying this criteria resulted really in the first major revision of the ambulatory surgical center list in 1987. In 1995, CMS adopted a modified standard for ambulatory surgical center list maintenance that allowed for minor fluctuations in utilization across settings and accounted for site of service errors from the National Claims History file that was used to determine qualification for the list. In 1997, the Balanced Budget Act proposed a new prospective payment system for hospital outpatient service based on APCs. Included in that was the requirement that a new rate-setting methodology be used for ambulatory surgical centers prospective payment system. The new payment rates would be calculated using 1994 survey data. The BBRA did require a 3-year phase-in period be used for implementation of the new APC system for ambulatory surgical centers. However, 1 year later, the Medicare, Medicaid, and CHIP delayed implementation to January 1 of 2002 or after, and extended the phase-in period to 4 years. Implementation of the APC system for surgical centers and the payment rates did not occur. CMS was not able to focus on the ambulatory surgical care setting because of the resources available were dedicated to implementing the outpatient prospective payment system. In January of 2003, the OIG issued results of the payments for procedures in outpatient departments and ambulatory surgical centers study. The results showed there was a need for greater similarity in payment rates between hospital outpatient and ambulatory surgical care settings. One study revealed the difference in payments for the same services performed in an ambulatory surgical center versus the hospital resulted in additional costs of $1.1 billion to the Medicare system. So because of those findings, the OIG recommended that CMS should really seek authority to set rates that are consistent across sites and that reflect only the costs necessary for efficient delivery of health services, that they conduct and use timely survey data to determine the payment rates, and that they remove procedure codes that meet deletion criteria. The Medicare Prescription Drug Improvement and Modernization Act of 2003 repealed the survey requirement or the need to collect updated cost data. More important, the MMA requires CMS to implement a revised prospective payment system for these ambulatory surgical centers between January 1 of 2006 and January 1 of 2008. So therefore, the revised prospective payment system for ASCs was effective January 1st of 2008. This prospective payment system utilizes the HCPCS coding system. It allows for yearly update for code changes. The scope of services expanded for the calendar year 2008 to more than 700 codes. The payment rate in this system is based on APC group relative weight. Unlike the previous prospective payment system used in ambulatory surgical centers, APCs allow for separate payment for certain ancillary services and supplies, like radiology, for x-rays, brachytherapy, drugs, some implantable devices, and corneal tissue. Payment methodology is modified for certain device-intensive procedures. Each year, a listing of those procedures is published in the Federal Register. The list consists of those procedures where the device offset percentage is greater than 50% of the median cost. When multiple procedures are performed during the same surgery, a payment reduction is applied. Each year, services applicable for the discounting provision are identified in the Federal Register. The procedure with the highest weighted APC is reimbursed at 100%, and all remaining procedures at 50%. Bilateral procedures are reimbursed at 150% of the payment rate for their group. A 4-year transition phase was established for the migration to APC payment for the Ambulatory Surgical Center Prospective Payment System. Although the APC grouping and provisions will be used, the payment rate will be a blend of 2007 group rates and the applicable year base payment rate. Coding and billing personnel need to follow 5 steps when obtaining payment. 1. The procedure or service is coded using the HCPCS coding system. Step 2. The APC group is identified based on your HCPCS code. Step 3. Multiple procedure and bilateral procedure provisions are applied when applicable. Step 4. The payment for the established group is wage indexed. And finally, step 5, payment is made to the facility. Next, we will be discussing the end-stage renal disease prospective payment system. Benefits for end-stage renal disease patients have been included under Medicare since 1972. Benefits are provided for persons who have permanent kidney failure requiring either dialysis or kidney transplantation to maintain life and meet other eligibility requirements regardless of their age. So why did we need a prospective payment system just for this one specific condition? Well, in just 2009 alone, Medicare spending for dialysis services totaled $9.2 billion. To put that into perspective, in 2009, Medicare also spent $45 billion for all outpatient facility services. So renal dialysis services accounted for about 20.4% of all outpatient facility expenses. Medicare began covering end-stage renal disease under Medicare in 1972 under a cost-based payment system. OBRA of 1981 required Medicare to make changes to the payment system to establish a prospective payment. In 1983, a composite rate was implemented. Over time, a significant portion of the services, including specific drugs used to treat the condition that was associated with dialysis, were excluded from the composite rate and were paid separately from that rate, and they grew to about 40% of the total expenses. So instead of having a purely prospective payment system, Medicare was reimbursing dialysis service under a mix of prospective payment, fee-for-service, and other payment mechanism and rules. On April 1st, 2005, Medicare did implement a basic case mix adjusted composite payment system that was developed from research conducted at the University of Michigan. In 2010, MIPA mandated a bundled payment system for end-stage renal disease to have a prospective payment system. Specifically, the law required Medicare to create a single payment system that bundles all services associated with dialysis. This was not easy because of the significant variation in resources required for providing dialysis. Implementation was January 1st of 2011. The proposed rule was released in July, with the final rule in November. On January 1, the new definition included all services historically known as renal dialysis, including the composite rate, and expanding to incorporate drugs, lab tests, and supplies that were previously separately billable and reimbursed outside of that composite rate. The base rate under the prospective payment system is based on the average per treatment cost for renal dialysis services. Several adjustments are provided at the facility and the patient levels to try and adequately reimburse facilities that have a patient population of high resource intensity. A facility-level adjustment is provided to account for wage differences among geographical areas. The labor portion of the base rate amount is 41.737%. This is based on the geographical area to define urban and rural facilities. A low-volume facility adjustment is included in the end-stage renal disease PPS to allow for adequate access to care for Medicare beneficiaries. This adjustment will allow for small facilities to continue to provide dialysis services even though their unit costs are typically higher than those facilities who have a higher patient volume. Two requirements have to be met to qualify as a low-volume facility. First, the facility has to furnish less than 4,000 treatments in each of the 3 preceding payment years. The second criteria is that the facility has not opened, closed, or received a new Medicare provider number because of a change in ownership during the 3 preceding years. After using 2006 to 2008 data, CMS determined the appropriate adjustment for low-volume facilities is 18.9%. If a facility qualifies for a low-volume adjustment, but during the current payment year determines that they have furnished more than 4,000 treatments, the facility must notify their MAC and request to no longer have the adjusted applied to the treatments. The regression analysis that was used to develop the end-stage renal disease prospective payment system indicated that age explains a significant portion of the variation in resource intensity for dialysis. It was determined that both the youngest and the oldest categories were the most resource intensive, as you can see on the table on this slide. It is also required that we take into account a patient's weight, BMI, and other appropriate physical factors. During analysis, Medicare evaluated a patient's height and weight as predictors of resource intensity. The analysis showed that only low BMIs will have a significant impact on resource consumption for dialysis services. Therefore, an adjustment is provided when the BMI is less than 18.5. CMS also considers an adjustment based on the length of time the patient is on dialysis. Studies showed During the first 4 months of dialysis, the costs for providing services are significantly higher. Therefore, an adjustment is provided for all treatments during the first 4 months. However, the individual must be eligible for Medicare end-stage renal disease benefit at the time of treatment delivery. ICD-9-CM diagnosis codes for all documented comorbid conditions should be reported on the claim form. The codes must be reported in compliance with the official coding guidelines. All conditions should be reported regardless of whether the condition is on the adjustment list or not. Under the end-stage renal disease prospective payment system, there are 6 comorbidity diagnostic categories for which a payment adjustment is provided. Those categories are listed on this slide. CMS does provide for a pediatric adjustment that combines age and modality. There are 2 modality categories, peritoneal dialysis and hemodialysis. The pediatric adjustments are provided that are listed on the screen here. You can see the age, the modality, and then the payment modifier. The outlier policy is fairly complex, but it basically states that a facility is eligible for outlier payments when its MAP amount per treatment for outlier services exceeds the outlier threshold. The threshold is equal to the facility's predicted MAP amount per treatment for the outlier services plus the fixed dollar loss established for the year. Outlier payments are estimated to be 1% of total payments for end-stage renal disease, PPS. CMS did determine that an add-on payment for self-dialysis training on a per-treatment basis was warranted. In addition to there being an enhanced quality of life via home dialysis, CMS also agreed with comments that the staff required expertise necessary to provide the proper treatment. The payment steps are: 1, the wage index adjusts labor portion of the base rate to determine the wage adjusted base rate. Step 2, apply the following patient and facility level adjustments. Step 3, multiply the PM by the wage adjusted base rate to calculate your adjusted base rate. Step 4, multiply that adjusted base rate times the number of treatments provided for the month that you're going to report on your claim form. Step 5, apply any self-training wage index for each treatment where training was provided and it meets the requirements. Step 6 is to determine if the claim qualifies for any outlier add-on payments. If so, the outlier calculation should be done to determine the per treatment outlier add-on amount. Step 7, sum the results of step 4 through 6 to determine total payment for the month. Medicare did indicate in the 2011 final rule that they will work to improve the Medicare program data, and many comments were received from the healthcare community. But it did require a 4-year transition period. 87% did start to receive payments on January 1 of 2011. Once Medicare has a sufficient amount of claims data in the database, they will again begin to evaluate and probably make changes to this prospective payment system.